It's a Northwest lifestyle weekend on Como News. This is IRG's Health Talk. Back to Tom Hutler and Shannon O'Kelly.
Welcome back. Guest number 2 today, Dr. Jeremy Idjadi, orthopedic surgeon from Whidbey Health Orthopedic Care, doing a little segment today on shoulder instability. We've heard about this. Your shoulder isn't really completely messed up, but you've got some issues in there where you're not fully locked in with your rotator cuff holding it in and everything like that.
Wow, Tom, you are getting really good. Yes, it's a lack of stability, or what we call instability of the shoulder. Again, big ball, small socket, a lot of movement potential, and you stretch that tissue out and you have an unstable shoulder.
All right, let's hear what Dr. Idjadi has to say with Shannon O'Kelly.
Dr. Idjadi, welcome. How are you doing?
Thank you very much for having me. I'm doing great.
Tell us about your practice. I understand you're an orthopedic surgeon and you focus and specialize in sports medicine extremities. But tell us about your practice.
In fact, I am a sports specialty trained orthopedic surgeon. I've been in practice for about 14 years, and most of my practice has been, over the majority of that time, orthopedic sports medicine, which involves arthroscopy and surgery of the shoulders, elbows, knees, and any other orthopedic sports problem. And then I also practice and do general orthopedics, which would involve fracture care and total joints.
All right, so tell us, do you have a fellowship then in orthopedic sports medicine?
Yes, indeed. Yeah, I did a fellowship at Carlin Job Orthopedic Institute down in Los Angeles, where we took care of many of the professional teams down there and got training not only with actual diagnosis and treatment of sports medicine conditions, but also the surgery and then team care as well.
Wow, Carlin Job, that's a very well-known institution down in Southern California. Like you said, a lot of professional athletes come in for care, and we're going to talk about the shoulder today. Tell us anatomically, maybe a brief anatomical, set the shoulder joint up. It's an interesting joint, it's complicated, and it's fun to work with.
Absolutely. One of my favorite joints, one of the parts of the human body I'm very passionate about. And I think a good way to think about it would be as a ball and socket joint. Many people are familiar with that concept. Another way to think about it is a golf ball sitting on a golf tee. If you look at a golf ball on a golf tee, oftentimes that can be quite unstable if the wind comes by and knocks the ball off the tee. And so there are many structures that keep the ball on the socket. There is a cartilage rim called the labrum, and then attached to that labrum is what's called the joint capsule. And within that capsule, there's ligaments, which I would think of as guy wires or cables that hold things in place. And then I would add to those stabilizers of the shoulder joint the muscles, such as the rotator cuff and the biceps. The rotator cuff being the group of muscles that surround the ball and socket joint, and the biceps being the muscle that most people are familiar with in the front of your arm.
When you're talking about the capsule and the ligaments, sometimes in the business we talk about intrinsic stabilizers and extrinsic stabilizers. So the capsule and ligaments are the non-contractile tissue, and they're stabilizers in the joint. And then the extrinsic or rotator cuff, bicep, those are muscles that stabilize from contraction.
Yeah, Shannon, I think that's a great point. And a lot of times people can identify with, let's say, a guy wire holding up a telephone pole, and presumably that's not going anywhere. It's not very stretchy. It's a steel cable that doesn't have a lot of give, and that's the way I would think of the ligaments. And then, of course, the muscles, most people are familiar with muscle contraction, like you said, which will provide that extrinsic or dynamic stability.
Yeah, good stuff. And from a mechanical standpoint, the uniqueness about the shoulder joint is that configuration of a large ball and a small socket. You have a lot of mobility, but with a lot of mobility, you sacrifice sometimes stability. And that's what we're going to talk about is shoulder instability. So tell us about shoulder instability.
You know, I would think of it in two broad categories. One would be an atraumatic instability and then a traumatic stability. Atraumatic, in general terms, would be somebody who was born with, let's say, looser tissues, in this case in their shoulder, which would allow their shoulder joint to come in and out of place a bit easier than their neighbors. And also in that category, you could have a overhead athlete who had repetitive use, let's say a baseball pitcher or a volleyball player who may over time get loose. I would contrast that with somebody who had a bicycle accident and dislocated their shoulder, or somebody who was playing football and dislocated the shoulder. That would be traumatic.
More with Dr. Jeremy Idjadi after this timeout on Como.
It's a Northwest Lifestyle Weekend on Como News. IRG's Health Talk continues.
We continue our conversation with Dr. Jeremy Idjadi and Shannon O'Kelly.
Okay, here we're back with Dr. Idjadi. We're talking about shoulder instability. Dr. Idjadi is an orthopedic surgeon on Whidbey Island, and he's got a sports medicine fellowship. And Dr. Idjadi, great job. You're describing the instability in the shoulder anatomy perfectly. And you talked about two types of instabilities. You talk about a non-traumatic and a traumatic instability. But when this instability occurs, can you correct those intrinsic stabilizers? What do you do as an orthopedic surgeon?
The ones that we typically correct surgically would be the intrinsic stabilizers like we touched on before, which would be those check reins or the ligaments and capsule. And that would typically be somebody who had a traumatic dislocation. In those cases, in a young person, we would often be forced to fix that because they're in a segment of the population who are very likely to redislocate their shoulder in that setting. I would contrast that to somebody who is born with a generally unstable shoulder, where oftentimes physical therapy would be the mainstay of treatment for a very long time.
So as a surgeon, when you're correcting that instability and that patient or athlete needs correction, you're going in and you're going to tighten those ligaments, or as you described, those cables.
Absolutely. And the way we typically would do it, and the results are quite good, is through an arthroscopic technique or a small incision technique. Years ago, this would be a very large surgery with a very large incision, and the results modern day are very similar with the arthroscopic approach that we take, which causes less trauma to the soft tissues, less pain initially for the patient, and similar results, being able to fix the broken structures.
How do you, maybe in a sentence or two, describe how you tighten up those structures?
I guess imagine a rope that's either detached from its anchor point or a rope that's stretched out. You have a choice of reattaching that rope back to its anchor point. So in that case, we would reattach the capsule and the labrum back to the socket, and we use small anchors, which oftentimes are absorbable devices that can hold it there as it heals. And then we could also take the rope and shorten it by doubling it over and then sewing it to itself, basically. And we can see quite a bit through small incisions with the camera, which allows us to get a much better vantage point oftentimes than even an open surgery.
It's really fascinating to watch this and watch you do these procedures. Tell us about return to play, return to activity post-operatively.
I would say that the highlight of that would be we can do a wonderful surgery, but if the patient is unable to, for whatever reason, have appropriate rehabilitation, then oftentimes the results aren't as good as they could otherwise be. And so physical therapy is a very integral part of this type of surgery and recovery. So oftentimes that will be 3 to 4 months of very intense physical therapy and home exercises, and then ultimately the patient doing a maintenance program after that, and perhaps getting back to impact or contact sports after 6 months at least.
Dr. Idjadi, again, thank you for your time. That was wonderful information, and thanks for joining us on Health Talk.
I really appreciate you having me today. Thank you very much.
We've been talking about shoulder instability with Dr. Jeremy Idjadi, orthopedic surgeon from Whidbey Health Orthopedic Care. Is instability something that you guys can treat and take care of at IRG?
Oh, absolutely, Tom. I mean, physical therapy is the first line of defense and treatment for an unstable shoulder.
All right, WhidbeyHealth.org for more info. Next, more on Como.